Thank you very much. And now we're moving to Dr. Saeed Al-Kaabi, who will be talking to us about COVID-19 and insomnia. Again, Dr. Saeed Al-Kaabi is the head of the Neuromodulator and Sleep Disorder Unit at Al Masarra Hospital in Oman. Welcome, Dr. Saeed.
Assalamu alaikum wa rahmatullah. Good evening. Good evening, everybody. Just want to make sure, is my voice clear?
We can hear you, Bob. Yes.
Okay. Okay. So first of all, I would like to thank you for having me today with you. I would like to especially thank Dr. Mohammed Faqani for this invitation. I will be today talking about insomnia during this difficult time of COVID-19. One note is that I'm very bad in time management, so please stop me if I am going by the time or I'm going too fast. Feel free to just stop me. Yeah. So first of all, I have nothing to disclose. This is the outline of my talk. So today I will be talking. In the beginning, I usually like to do is talk more about the importance of sleep, since we will be talking about difficulty getting the sleep. So it's important to talk a little bit, spend some time talking about the importance of sleep and why do we need to sleep. And then we'll spend some time talking about the assessment of insomnia, because I think this is very important and it's crucial in the management of this disorder. Then we'll talk in general about insomnia, some figures and numbers regarding the prevalence all around the world. And we'll end with briefly about the management. We will not go deep in management, it's just general headlines. So, to start about the importance of sleep. So do we need to sleep? So what we don't sleep? So we know that sleep. So when they sleep deprived rats, after 2 weeks, the rats die. So rats need to sleep. What about humans? Of course, we can do such experiment in humans. So, but there is a genetic disorder called fatal familial insomnia. It's an autoimmune prion-like disorder. There's a mutation of one of the amino acid. So what will happen? The patient at the 30 or 40 years of old, they will just lose their ability to sleep. And after that, they will just die. 2 weeks, 3 weeks without sleeping, they will die. So this is one example of importance of sleep to human. So, sorry. So what about mammals? So sea mammals, if they sleep, they will sink and drown. So how do they sleep? So instead of just eliminating sleep, because the sleep is very important, they found that the sea mammals sleep with half brain at the time. So they will keep swimming with half a brain and sleeping with the other half. So this gives us some hints about the importance of sleep in everyone. So this is Dr. Muhammad mentioned regarding this briefly regarding the importance of sleep with the immunity, and this is one study regarding the hepatitis A vaccine. So in this study, there is 1 night of sleep deprivation after the immunization in a group of people. So in that group, what they noticed that after 4 weeks, the antibodies in the blood were reduced almost to have 50% reduction in antibody response to the immunization with only 1 night of sleep deprivation. So this is tell us how important is sleep for our immune system. For insulin regulation, they sleep restrict a group of students to 4 hours only. It's not a total sleep deprivation, it's just reducing glucose clearance rate down was decreased by 40%, and the acute insulin response down by 30%. at the end of the study. And this is only with the sleep restriction to 4. I know about the importance of sleep in satiety hormone, hunger hormone, which can lead to obesity and other metabolic syndrome. So it's showing me that the connection is unstable. So please let me know if it's not clear. Okay. So sleep and emotion. So as you know, that sleep is one of the symptoms in most of the psychiatric disorder. It's a main symptom of depression, anxiety. If you are not able to sleep, you will become more volatile. Your suicidal risk increased with the sleep deprivation. Sleep and learning also. Sleep has been shown it's very important for learning new information. As you know, the hippocampus, which is the temporary storage of information, which will usually fill up very quickly. And without sleep, you will not be able to make a new information. So sleep to make a room for a new information to learn. And this study showed that those group of people who were sleep deprived did very bad in learning tasks. Similar with the deep sleep, slow wave sleep, it's very well known that slow wave sleep is very important for us for a memory consolidation and for like a long-term memory. So what did here in this study, they did a brain stimulation just to increase the amount of the deep sleep. It's well known that transcranial current stimulation can increase the deep sleep. So they did that to just compare the two groups. So those groups who had the brain stimulation and their deep sleep was expected to be high perform much better in the memory test compared to the other group. Other important area is the relation of sleep with Alzheimer's disease. So it's very well known that sleep helps with the clearance of beta amyloid, which is the main cause of Alzheimer's. So this is very important. Sleep slowing reaction time, microsleep, and impaired performance. And in this national survey in US, they found that 1 in 5 car crashes is the result of drowsy driving. So as you can see, the health consequences of sleep deficiency. This is just a few of the area that sleep have important impact on it. When we talk about the sleep, we talk about the duration. So like for adult, they need 7 to 8 hours. The timing, it should be at the expected time for sleep. And the quality of sleep. What do we mean by quality? That we have to exclude any like primary sleep disorder like sleep apnea or restless leg or others that can intervene with the sleep quality. So getting a full night of good quality sleep can make you more alert, more active, live longer. And a side note, according to this study, sleeps make you more attractive to other people. So let's go and start talking about the insomnia. So insomnia is a major healthcare problem all over the world. The prevalence around 6 to 10% of adults that meet the diagnostic criteria. It's of course more common in women and older adults, and it can be secondary to can be primary. Usually, it's associated with fatigue, poor cognitive function, mood disturbance, and stress or interference with personal function. So, as we mentioned, epidemiological studies demonstrate marked impairment in functional status among those with chronic insomnia. So, it's a really disabling condition. There is an increased rate of work absence and occupational and motor vehicle accident, as we showed earlier. Significant risk factor for development of a psychiatric disorder, as we mentioned also. And there's a more recent investigation suggested that chronic insomnia is associated with increased risk of cardiovascular disease. And an estimated cost of around 2 to 16 billion per year in the US and an indirect cost of 75 to 100 billion. The diagnostic criteria, why do I further about the diagnostic criteria of insomnia disorder, because not everyone complaining of difficulty falling asleep is suffering from insomnia disorder. So it's very important that we know the diagnostic criteria and the patient fulfilling the diagnostic criteria. So this is the DSM-5 diagnostic criteria for insomnia. And it said that dissatisfaction with sleep quality or quantity associated with at least one of the following: difficulty initiating sleep, difficulty maintaining sleep, early morning awakening, plus associated with distress or dysfunction related to sleep, plus minimum of 3 times a week for at least 3 months. And this is usually what people doesn't pay attention to it. It must be some have been going for sometimes like 3 months, and it must be having direct impact on person function and daily living. And this is the very important slide. I usually stress on it. And unfortunately, most of the physicians do this mistake. When we find an insomnia, we quickly start to think about what we give these patients. We don't go to the differential diagnosis, which is a big mistake. And I will stress on just considering insomnia a symptom of unknown origin, and we should look for a differential diagnosis, then to reach a diagnosis, and then to think about treatment. Unfortunately, I have seen many patients with insomnia who have been seen so many physicians and already started on multiple medications without even thinking about what is the possible cause of insomnia. So this is a very crucial in the assessment of insomnia. So this is some of the differential diagnoses that can lead to insomnia disorder. Psychiatric disorders should be first on the list. Depression, anxiety, other post-traumatic stress disorder, other psychotic disorder, all can present with insomnia symptoms. Primary sleep disorder like sleep apnea, restless leg syndrome, parasomnia, all these can have insomnia symptoms. Medical illness, medication, poor sleep hygiene also can be one of the reasons for insomnia. So this is briefly about the definition and how we should assess insomnia. Let's move to talk about insomnia during this difficult time of the pandemic of COVID-19. So it's very clear that the number of patients who suffering from insomnia have been dramatically increased. We have noticed this in our clinic, and for me, that's like 90 to 95% of the cases who's coming to my clinic with insomnia during this time, it's mostly related to stress, anxiety, or depression. So let's look at some of the studies. Unfortunately, most of the studies have been done in China, but I found some of the systemic review and meta-analysis that cover most of the articles. So this one included 55 peer-reviewed study, meta-inclusion criteria for the meta-analysis, and we can see here that the prevalence of depression 3 times increased, anxiety 4 times increased, insomnia 3 times increased, post-traumatic stress disorders 3 times increased, and psychological stress also almost doubled. Group difference were only found in healthcare workers who had higher prevalence of insomnia than others. Otherwise, there's no significant difference between other groups. So this is one of the study that looks up these symptoms among affected people with COVID-19. This is also an interesting systematic review with prevalence of depression, anxiety, and insomnia among healthcare workers during the COVID pandemic. And there's 13 studies were included in the analysis with combined total of 33,000 participants. Anxiety was around 3 times increased, depression same, 3 times increased. Insomnia was very high, around 40% across 5 studies. And a subgroup analysis revealed a gender and occupational difference with a female healthcare practitioner nurse exhibiting higher rate of affective symptoms, including insomnia. Last study I want to mention is this one we have done here in Oman. It's about the psychological and sleep-related factor among quarantine Oman students returning from abroad. So this was a cross-sectional study conducted among Omani students who came back to Oman from abroad. During the study, anyone entering Oman had to be quarantined upon their arrival for 14 days. So the participants were allowed to acclimatize and overcome possible jet lag for at least 8 days. Then they were required to complete the study survey on day 8 after the arrival. So excluded from the study were those who having prescribed medication or pre-existing medical or sleep-related disorders. Some social demographic characteristics were gathered in one of the assessment tool, and the other assessment tool were Athens insomnia scale and generalized anxiety disorder scale. So basically, what we have found from this study that the insomnia rate is very, very high. It's around 50%, and it's similar with the anxiety. Female students were 2.4 times more likely to suffer from insomnia when compared to male students. So how increase the insomnia and other psychological disorders. So what could be the contributing factor to insomnia during COVID time? There's so many contributing factors. Just social distancing, school closure, quarantines, and working from home all bring profound change to normal routine for people of all ages and walks of life. It can be difficult to adjust to a new daily schedule or even lack of schedule. Keeping track of time and even the day can be hard without typical time anchors like dropping kids at school, arriving at the office, attending a recurring social event, or going to the gym. Also, being stuck at home, especially if it has low level of natural light, may reduce light-based cues for wakefulness, and this can disturb the circadian rhythm, as you know. Also, if you are not working or your working hours is decreased due to the COVID-19, you maybe tend to oversleep each morning. Sleeping more than 7 to 8 hours per night can make waking up time much more difficult, even if you use an alarm. Oversleepers may also feel groggy, irritable, and unrefreshed during the day. So this is some of the contributing factor to insomnia. Also, excessive screen time, checking the news on your phone, joining Zoom with the family, watching Netflix, or putting extra hours staring at your computer, all can lead to aggravate insomnia symptoms. So excessive screen time, especially later in the evening, can have a negative feedback on your sleep. Not only can it stimulate the brain in a way that makes it hard to wind down, but blue light, as you know from the screen, can suppress the melatonin, a hormone of the body that makes you sleep. So this is regarding the screen time, anxiety, and worry. And this is, to be honest with you, most of the patients with insomnia having some symptom of anxiety. So what could be the reason? Most of them, they are fear of catching the virus or infected other people, as most people have the close friends or family who are older or at high risk group. Economic concerns are affecting nearly everyone, and this is all over the world. Some lost jobs, some of them having loans at the bank, and this can also increase the worry and anxiety. And there is also still much unknown about this pandemic, how long lockdown will last, whether hospital can manage the crisis, when life will return to normal. All these things increase the anxiety and disturb sleep. Depression and isolation. And this is really very serious. I have seen many cases referring for insomnia, and after thorough assessment, it ends up the patient is very critical, is having suicidal, and he is in high need to be admitted inside the hospital for his safety and safety of others. As you know, the crisis can trigger feeling of isolation and depression that may be even worse for people who have loved one who is sick or has passed away because of COVID, grief and depression can be exacerbated by isolation at home. And this can also significant sleeping problem. Depression can be more than just feeling sadness. Other symptoms may include loss of interest, loss of pleasure in activity, feeling of hopelessness or worthlessness, low appetite or overeating, disturbed sleep, thinking of ending life and suicidal idea. All this should be part of the assessment with patient of insomnia disorder. So this is in general about general population about the contributing factor of insomnia, and these are some of the related to healthcare worker. Increased workload, physical exhaustion, inadequate personal equipment, nosocomial transmission, and the need to make ethical decision on the rationale of care may have dramatic effect on their physical and mental well-being. And maybe all of us have experienced this. Their resilience also can be further compromised by isolation and loss of social support. Risk of infection of friends and relatives as well drastic, often unsettling changes in the way of working. So all these can contribute to the stress, anxiety, and eventually the insomnia in healthcare work. So let's move to the last part of the presentation, which is the treatment. And here I wrote the biopsychosocial. This is how we should think about treatment of insomnia: biopsychosocial, biological treatment, psychological treatment, and social treatment. First of all, we have to go do thorough assessment, go through differential diagnosis, try to find the diagnosis, then think about the treatment. First of all, you have to stress on the sleep hygiene. I know it's not enough for people who are suffering from insomnia, but this should be also stressed on and should be followed with the treatment. Some to mention standardized wake time. It's very important to have a regular sleep schedule. As you know, the circadian rhythm is one of the sleep drive mechanism, like hemostasis drive and circadian. So this is very important to have a very regular going to bed and wake up time. Do not to disturb the circadian rhythm. Limit amount of time in bed, limit napping, remove clock from vision, avoid caffeine, all these things, and to do some physical activity. All these sleep hygiene should be stressed on while considering treating insomnia. The next step, which is the first line treatment, it is not the medication. And unfortunately, this is, nobody follow this because maybe it's not available or people not aware of it. A CBTI, which is a CBTI for insomnia, it's a little bit different from the CBT for cognitive behavior therapy for depression. This is cognitive behavior therapy for insomnia, and it have so many components. It's most of them similar to the cognitive behavior therapy for depression, but this one is totally different with the sleep restriction. But unfortunately, we don't have enough trained psychologists who can offer this treatment. And here I just put that two application apps for CBT, which is as far as I know, that are the most evidence-based and free applications that can be used as a CBTI by the patient himself. Insomnia coach and CBTI coach. This is the recommendations before starting the pharmacological treatment. So this should be should be directed by the symptom, treatment goal, patient preference, the cost. All these should be considered before starting medication. On the other hand, you should involve the patient with the treatment, because if the patient doesn't understand the course of the treatment and what we are focusing on, most likely he will have a poor adherence to this medication. So this is just a general outline of how I would think treatment of insomnia in general. Of course, as I said, the most common reason of insomnia in COVID is anxiety and depression. So usually I will change this order and will go with the sedating antidepressant. I have very good feedback with mirtazapine, Romiron, which is tackling the insomnia and the anxiety or the depression. The only side effect with Romiron is the increased weight gain and appetite. But there is other options, like for example, sometimes if I'm facing a patient who is overweight, that no way I can write mirtazapine and I don't have other options, I will go with the regular SSRI and I will start with a short course of benzodiazepine. So benzodiazepine have most people, they don't like it because of risk of addiction, but if you know what you do and you are giving it for a short course, combined with an SSRI, if you are treating anxiety, this is a very, very good treatment. So this is, if there's a primary insomnia, there is no obvious cause, this is the order I will go. I will start with the benzodiazepine receptor agonist, melatonin agonist, like Ramilton, orexin antagonist, sedating antidepressant, anticonvulsant like gabapentin. Then down the list, antipsychotic like thiamine, sertraline, olanzapine, or risperidone, and the last thing like clonidine or hydrazine, which usually antihistamine, I try to avoid as much as I can. Just to mention about the benzodiazepine receptor agonist, here I mean the Z drugs and the regular benzodiazepine. So what I want here to stress is on this one. So please think when you are giving the patient, before giving the patient the benzodiazepine, think of the half-life of the medication. So for a patient who is unable to fall asleep, like you want the patient to sleep for 6 hours and you're giving him a medication for 40 hours half-life, this is a crime. I think unless you are treating other symptoms like anxiety. So think of the medication with the half-life. So I will go with these medications who have short half-life rather than thinking about long-acting medication. You know about the Z drugs. We have zopiclone, zolpidem, Zabilon. So zopiclone and zolpidem is usually for initial and maintenance insomnia, and the last one is only for initial insomnia because it's a very short half-life. The benzodiazepine, all of you knows about the short-acting like Xanax, intermediate-acting like Ativan or lorazepam, long-acting like clonazepam, diazepam. So please think of half-life before starting the medication and be aware of the side effect of this medication before giving to the patients. Like when you are giving to the elderly, make sure that there is a risk of fall and memory issue. Melatonin agonist like Ramilton is another options, and it is have little risk of abuse, and usually the half-life is 1 to 2.5 hours. This is not Bilsoma is not available, I think, here also in UAE as far as I know, but it's very nice medication for sleep maintenance insomnia. Antidepressant, as we discussed, mirtazapine is a very good options. Doxepine is a very, very good FDA approved with a lower dose than the antidepressant dose. This is 3 to 6 for insomnia. We don't have it here in Oman, unfortunately. And the other antipsychotic or antidepressant also can be used. Gabapentin also can be used, but make sure that it will abuse risk and other side effects. Antipsychotic, I rarely use antipsychotic because we are not using it for its side effects. So I try to avoid it as much as possible unless the patient have really psychotic symptoms. And this is the American Sleep Association recommendation that this is not recommended for treatment of insomnia. This melatonin and valerian or like antihistamine medication, we should try to avoid it as much as possible for patients with chronic insomnia. Please remember that we are talking about patients with chronic insomnia. So this is the end of my presentation. Thank you very much for your attention and happy to answer any questions.
Thank you very much, Dr. Saeed. Very formal and really you went through all the types of insomnia and the management is to the point. I have few questions here. One of the question is there is any association between the antiretroviral given during the COVID-19 and insomnia? Could it be a side effects?
To be honest with you, I'm not sure about the right answer, but I have read something that there is a relation between this medication and insomnia, but most of like not an evidence-based, it's just case studies. It's not like for sure, yeah.
Okay. Now the remaining questions, interestingly, is insomnia affecting the immune system in COVID-19? And the answer is yes, and you did really have a nice slide there. Thank you.
Yeah, you have mentioned that also. Thanks.
Yeah. Now someone is asking about sleep disorder in postmenopausal women. If they're talking from respiratory point of view, I could answer that. The postmenopausal women, because of the lack of estrogen, they increase the risk of obstructive sleep apnea. And you see, normally the women's below 40 and or before the menopause have a much more lower risk of obstructive sleep apnea. But as soon as they reach their menopause, and because of the lack of estrogen, the risk will be equal to the male adult. And that be related to also the dryness of the upper airway and the hardness again, and the loss of the dilator function of the estrogen. Now, in depression, the sleep apnea is central. Well, this is a weird question. I don't know what it means. During COVID, can we consider insomnia as part of the post-traumatic stress disorder? This is for you, Dr. Kaabi.
Yes. So the definition of post-traumatic is just like you have a traumatic accident. It doesn't have to be like life-threatening, but it has to be like strong enough to cause a trauma. So it doesn't have to be like a disaster or like a death of some family member or some close. We have seen cases who have like close friend having COVID-19 and he passed away and presenting with the typical symptoms of post-traumatic stress disorder. So yes, the answer is yes.
So from your experience, Doctor, you did say that many of the patients are coming with anxiety. And you did mention your experience again with some of the antidepressants like mirtazapine. And if you have to step up with something else, would you go to the Z drugs or the benzodiazepine?
Well, for anxiety, I will go for benzodiazepine. The Z drugs has, as far as I know, has no anxiolytic effect, but the benzodiazepine has a very good anxiolytic effect. That's the reason why I would use the Z drugs mainly for primary insomnia, but for people who's having anxiety and insomnia, usually I start with the short course of benzo and an SSRI. This will help the anxiety and will cover the side effect when you're starting the SSRI, and also it will increase. The SSRI will kick in very fast with the help with the benzodiazepine.
Okay. Now we know that the SSRI and many of them can by itself cause insomnia. So can you tell us more about how you use it? Do you give it during the daytime instead of the nighttime, or do you use a sedative SSRI?
Yes, that's a good question. So we have like an alerting SSRI like fluoxetine, Prozac. So this usually giving in the morning. On the other hand, like paroxetine sulfoxide is very sedating and it helps with the sleep. But to be honest with you, there is no much of like insomnia with the SSRI, but there is some other issue with the REM suppression. So the patient will come complaining of like vivid dreams and he's dreaming a lot now. And then you will know that his SSRI is suppressing his REM sleep, was making his REM sleep very fragmented. So this is one of the side effects that we have to change the SSRI or just make it more during the daytime instead of night dose. So for me, paroxetine, escitalopram at night is helping with insomnia, and I didn't see much of worsening symptom insomnia, because at the end we are treating the underlying cause. This is the thing that I want to stress in. Please take time to find the cause of insomnia. If you're just starting to cover the patient with the sleeping pills or sedating medication, you are not helping with the insomnia. As I mentioned during COVID, most of the cases because of the anxiety. So targeting the medication that help with the anxiety will solve the problem, even if it will be delayed for weeks. But at the end, it will help with the anxiety.
And what would be your course for alprazolam? Like, for how long would you continue? Would you give it for a month or more?
Usually I give it for 2 weeks, but usually I prefer to give lorazepam or clonazepam. Clonazepam, I will not give it for people who are having primary insomnia, but for anxiety,
it seems that we lost the connection with Dr. Saeed.
Oh, sorry about that.
Yeah, so that would be the last question, Dr. Saeed. I know that you may be having some internet connection issues.
I didn't know what happened. It's full signal here, but maybe, yeah.
Sure. So what would be your course normally for someone with insomnia related to anxiety? When you give benzodiazepine, for how long, and would you taper it down?
Okay, so first of all, before starting the benzodiazepine, I'll make sure that the patient is not having an addiction potential, that young patients or having history of some drug abuse or something, this is a big no to start any benzodiazepine. Second, I will, if it's associated with anxiety, I will avoid the short acting. I will look for something like lorazepam or clonazepam, because this will help with his anxiety and sleep. So I will avoid the very short acting, because it's very quickly the patient will get used to it, and it's a very addictive medication. Usually my course will be 2 weeks. Most of the patients will have a rebound insomnia after the 2 weeks, but I give them a very thorough information about the expected course of the medication, and they may have a rebound insomnia, but there is no worry, that will resolve within a few days. And most of the time that works, 2 weeks is enough. There's special cases that need longer, like a month or 2, but that's a very, very exceptional cases.
Well, thank you, Saeed. The last question from Dr. Raushan here, she said, is hypersomnia also a complication of COVID-19?
Well, I'm not sure about that, because we know that the hypersomnia, most of the cause are central, unless we are talking about the poor sleep quality because of the sleep apnea or other primary sleep disorder. But regarding the direct cause of central cause of hypersomnia because of COVID, I'm not sure about it.
Well, maybe I could answer here. We've seen idiopathic hypersomnia post acute infection and acute viral infection, and it's well described. So, and I would say, yes, it could be a secondary also to COVID-19. And we see, unfortunately, with the long COVID, we see people with a chronic fatigueness and insomnia, but also it can present as a hypersomnia. Well, I think this is really interesting. We still have many questions, but again, time is, it's almost, well, it's 4 minutes past 9:30. I'd like to thank you all. Thank you for attendance. Today we have more than 1,000 participants. Thank you all. If you have, I left my email on my slides, but you can always drop us an email. Instagram, UAE Sleep, if you wish. Your CME certificate will be received, will be sent to you via email. The email basically will have some questionnaires, and I guess there's an instruction on how to get it from TEM portal. For those who are residing in UAE, for people outside UAE, you're lucky you'll get the certificate immediately without. So thank you again, and I wish you a good night.